Welcome to another Prodigy EMS webinar. We are so pleased that you could join us today. I am Hillary Gates, Director of Educational Strategy at Prodigy EMS, and today's topic is Obstetric and Gynecological Hemorrhage, the Priorities of Care. This education is supported by LifeFlow, and thanks to them, you'll receive free CAPC credit for today's webinar. Our speakers today are Dr. Mark Piehl, who is the Associate Medical Director at WakeMed Mobile Critical Care and the founder and CMO of 410 Medical. We also have Dr. Maia Dorsett, an EM and EMS physician and EMS Medical Director in the Rochester area. Maia is also the Medical Director for Prodigy EMS. Maureen Holtz is a veteran ER nurse and quality improvement nurse who is based in St. Augustine, Florida. And finally, we have Dr. Miriam McQuaid, who is an OBGYN currently practicing in New Mexico. And since my name doesn't start with an M, it's best that I jump off and let the Masters of Medical Management tell you all about moms and maternity. And one of the things that I didn't say about Maureen is that she happens to be a survivor of postpartum hemorrhage. Maureen, can you start with your story?
Thank you. My name is Maureen Holtz, and I am an emergency room nurse and have been for many years. And one of the things that I was asked to share with you was my experience as somebody who had a postpartum hemorrhage. Even though I am a nurse, I was not aware that having a increased number of cesarean sections would put me at risk for postpartum hemorrhage. And when I had my fourth child, I did hemorrhage postpartum. It was a kind of scary situation. My hematocrit went down to 26. And one of the things that I really underestimated was how short of breath you become when you are losing blood that quickly. It was very scary. Fundal massage was used, and you'll hear more about those things in treating these kind of emergencies. But I am here to just share that perspective with you, and from a patient perspective, let you know how scary it is and how much we need you all to be able to recognize it and treat it effectively.
Thanks, Maureen. It's a privilege to be here with all of you and discuss this important topic. I'm going to go ahead and go over a quick bit of background on obstetric and gynecological hemorrhage, and then turn over some of the conversation here to our experts. We'll also have another patient story for you toward the end. Just want to give my quick disclosure. I actually am a pediatric intensivist and an EMS medical director, and hadn't had a ton of experience with obstetric hemorrhage until I began working with my company 410 Medical, which produces a LifeFlow device, and we've had the privilege of having it used in a good number of women who are hemorrhaging and have severe hemorrhagic shock. And so I've taken a great interest in this topic and begun to do some research on it as well. So it's a privilege to be here. I'm sharing some of our knowledge with all of you, and let's get going. So interestingly, obstetrical and gynecological hemorrhage is the leading cause of maternal death worldwide. So it's super important. And it's also the leading cause of preventable death and morbidity among women in the US. And other causes that we should take into consideration that we won't really dive into this day, but are important, are mental health, postpartum depression and other mental health conditions, maternal sepsis, cardiomyopathies that develop during pregnancy, and things like thrombotic embolism. Interestingly, hemorrhage-related mortality among pregnant women is on the rise, interestingly, and mortality is on the rise as well. And this accounts now for over 10% of all maternal deaths. Most of these, as we'll discuss in the coming minutes, are due to postpartum hemorrhage. So we want to help folks know how to recognize and provide early management for postpartum hemorrhage. Maia, I'm going to turn over to you here for some of the physiology on postpartum hemorrhage.
Great, thanks. So I think big picture, sometimes it's really important that you understand sort of the normal changes that happen and the way things are supposed to work so that you can understand pathology in the context of how those normal processes are interrupted. One of the, I think the things that's truly amazing about pregnancy is that you actually essentially develop an entirely new organ that requires a lot of blood flow, specifically for the purposes of feeding the fetus. So if we think about sort of where is the blood flow coming from, there is a huge increase in blood flow to the uterus. So in the non-pregnant uterus, you get about 60 cc's per minute of blood flow. And by the third trimester, that goes up to 600 cc's per minute. So if we put that in the perspective of an organ that we normally think about bleeding, like the spleen, right, who we think about in the context of trauma, a normal spleen in a woman gets about 200 cc's per minute of blood. So if we think about in terms of trauma to the uterus, right, something like a ruptured ectopic pregnancy or a laceration to the cervix that occurs during delivery, you can automatically think about how quickly somebody might be able to bleed out from that. But also thinking in terms of what are the processes to sort of undo what is created for the purposes of sustaining a pregnancy. So within the uterus, right, the uterus is a massive muscle, right? It's a huge muscle. And within the uterus, there's arteries that come down called the spiral arteries that go down and actually feed through the endometrium and then to the placenta. And the placenta is actually derived from the fetus. And normally what happens is that you get uterine contractions. This lowers the surface area for the placenta to attach, actually causes rupture of some vessels underneath it and causes the placenta to go ahead and detach. You can do next slide. All right. So once the placenta detaches, if you have to sort of think about this, this is almost in the analogy of trauma, right? Like a planned amputation of an organ. And so there has to be a tourniquet that is going to be used to cut off those blood vessels. And essentially the uterine contractions are like living tourniquets, right? That clamp off the blood flow that goes into the uterine cavity. So any process that disrupts this, so the placenta doesn't detach properly and inhibits those uterine contractions, the uterus is not contracting appropriately, is going to interrupt essentially this process of like tourniquet application to these arteries that are communicating a huge amount of blood flow to the uterus. And so the big ideas that I want you to get from understanding this physiology, the first is that you should never underestimate the capacity of a woman to bleed to death from her uterus, sheerly because of the amount of blood flow that goes there. And the other thing is that one of the themes that we're going to go through in this talk is that you already understand a lot of what the priorities of care are, because you understand the priorities of care in hemorrhagic shock, which is the key presentation here. Miriam, do you have something to add?
Yeah, I guess I think that the thing that's really interesting to me about these spiral arteries is that they have no muscular layer, which is different than most arteries in the rest of the body. And it means that really without that contraction, they will continue to bleed. And that's why this is so dangerous when you don't have contraction. And we'll get to it later about how we can help increase that contraction.
Great. So let's talk about the big causes of obstetrical and gynecological hemorrhage. And there are many, and they have varied presentations. So there's one category of antepartum, which is placenta previa, where the placenta is not positioned maybe properly, or placental abruption, where it detaches early and causes hemorrhage. Then the biggest category of postpartum hemorrhage that can occur early, right after birth, or within the first 24 to 48 hours, or many days to actually weeks later. And so it can be something that comes to attention of EMS providers and emergency physicians many days after delivery. Then bleeding can occur after spontaneous or induced abortion. And then lastly, and maybe one of the hardest ones to diagnose, is the concept of ruptured ectopic pregnancy, where the fetus is actually implanted in one of the fallopian tubes, which can't accommodate its growth and ultimately ruptures that tube and causes severe hemorrhage.
So one of the things that I think is really important is terminology here. So Miriam, as our OBGYN expert, can you describe the term abortion and its different variances and what we mean when we say that?
Yeah, very generally, abortion means pregnancy loss. There are many different ways abortions can happen. There's the two that are described here are spontaneous and induced. A spontaneous abortion is what we call generally a miscarriage. And an induced abortion is someone doing something to cause their body to pass a pregnancy. That's either with pills or with a procedure, usually.
Maia, you want to go over the different stages of pregnancy here?
So I think what's sort of important is to actually have a sense of when we may expect to see these different complications, and know that these are sort of general guidelines where you're most likely to see it. And there's always going to be sort of cases that don't quite fit this. The main thing is ectopic pregnancy. The peak of identification of an ectopic pregnancy and rupture is 6 to 10 weeks. And that's usually because the pregnancy gets to a size and is a location where you have rupture. That can occur later, but usually this is something that is in the first trimester. And we'll talk about recognition, but very often that's before somebody actually knows that they're pregnant. As far as abortion, whether or not that's spontaneous or induced, that's usually going to be within the first or second trimester. And then placental complications like abruption, which is the separation of the placenta from the wall, often in the context of trauma, or previa, which is that abnormal implantation really over the cervical opening. Those are things that might start to present after 20 weeks of gestation up until the point of sort of the end of term.
Great. So let's talk about postpartum now. As Maia mentioned, the uterus during pregnancy receives up to a quarter of all the heart's cardiac output. So it's getting a ton of blood. And when there's a disruption of it from the placenta separating or uterine rupture or other causes, it can bleed heavily. And women can lose a lot of blood in a short amount of time. Severe postpartum hemorrhage is defined as over a liter of blood loss. It's super hard to quantify how much blood people are losing, especially when it occurs at home or out in the field. But that's one of the technical definitions. Some people define it as 1,500 mils. Miriam, do you have any comments on the exact definition there of what severe means?
Yeah, that changed recently. So yeah, it's 1,000.
And most of these are going to occur early, but as I pointed out before, they can occur many days after delivery due to retained placental tissue or other causes. And as we'll get into in a sec, uterine atony or lack of contraction of the uterus after delivery is responsible for most of the hemorrhage that we'll see in postpartum. And interestingly, relevant to EMS providers, postpartum hemorrhage is the most common cause or is the most common complication of home births, which we're seeing probably with increased frequency.
Atony also, as you said earlier, sepsis is one of the biggest causes of death from maternal hemorrhage as well. But sepsis can lead to worsening of uterine atony. And so that's something really important as well. If someone's presenting with a septic picture, don't count out atony and know that it will often be worse with the sepsis.
Good point. Good point. Maia, you want to go over the 4 T's?
Yeah. So this is an acronym that's used to help organize the causes of postpartum hemorrhage. And I think it's really important for EMS providers to think of this because I think it actually allows you to take a more algorithmic approach as to how you're going to care for these patients and manage the source of the hemorrhage. So the first T is tone, and that is uterine atony. What we mean by that is a uterus, right, that is not contracting down as it should. There's known risk factors for this. So if somebody has had multiple prior pregnancies, especially 5 or more, very high risk, almost assume that this is going to occur from that, a multiple gestation pregnancy, as well as some other risk factors, but it can happen in any pregnancy. The next is trauma. And so the situation we think of this is sort of immediately postpartum. You can get vaginal or cervical lacerations that can bleed quite heavily. The third is tissue. And what we mean by tissue is retained products of conception. So this is a significant issue immediately postpartum if all of the placenta doesn't detach. But this is also the issue when we talk about the bleeding complications of, abortion, is that if you have retained products, that will also lead to continuous bleeding because it will not contract down and clamp off those arteries. And then the last is thrombin. And what we mean by thrombin is coagulation abnormalities. So there are people who have pre-existing coagulation problems like von Willebrand disease, but there's also patients who are, for example, on Lovenox because they had a PE during their pregnancy, who are going to bleed more. And so those are all things that we should be thinking about when we take the history.
It's helpful.
And so the key thing here is actually sort of sometimes, right, when we're coming up with a working diagnosis, it's a game of probabilities. And so immediately postpartum, the money is on tone, okay? And given what we talked about in the physiology of what is the normal process, I hope that you understand why, right, uterine contraction is such a big deal. The next is going to be trauma, and then tissue is going to be a lower proportion from that. And thrombin is relatively rare, but that's something that you can gather by getting the patient history.
Why don't we talk about recognition? I'll let you start, Maia, and then we'll get into some of the recognition of shock.
Okay. So I think when we talk about the priorities of care, very often we want to jump to patient management. One of the things we're going to focus on is to recognize that it is happening, right? And the diagnosis not considered is 100% the diagnosis not made. So we have to recognize this, and we need to recognize it early. And once we've recognized, right, that this patient is at high risk of hemorrhage, then there's principles of care for how we prioritize our actions, right? So priorities include things like hemostasis. So just like if I had a trauma patient, right, with a femoral artery bleed, right, I would think immediately I'm going to apply a tourniquet that to minimize the further bleeding. I need to think the same way of what are the techniques I can employ to decrease the amount of bleeding that is going on. The next is filling the tank, which is resuscitation. And Mark, as our expert here, is going to go more into sort of what are ways that we can resuscitate and how do we guide our resuscitation. And then the last component is destination. Because if you think about the 4 T's, right? One, there's some of those T's that actually specifically require a surgeon, right? An OBGYN to remove those products of conception and evacuate the uterus, as well as in some cases apply advanced techniques. So we need to get them somewhere where somebody with that expertise is rapidly available and pre-notify so that we decrease the time to intervention. I hope, right, that I could change the title of this slide, right, to trauma, the priorities of care, right? These are things that you already know. I think when we talk about obstetrics, we talk about it as like special populations, but one of the key concepts are, these are concepts that you already know. You already know it matters, right? It's like stop the bleeding, fill the tank, get them to a surgeon. And the same thing applies here.
All right, so let's talk about the recognition of severe hemorrhage in both postpartum and ruptured ectopics. So for the obstetric, so postpartum hemorrhage, obviously the history is important. A recent delivery or a recent spontaneous or induced abortion, usually with heavy vaginal bleeding. And remember that the estimate of how much has been lost is usually low. There may actually not be. There can be internal hemorrhage that we're not seeing on the outside, but usually we'll see it. And then importantly, signs of shock. And I think this is where we could underestimate the severity of illness here. So heart rate generally over 100/110 and systolic generally under 90 is going to tell us this patient is sick. However, you don't be fooled by a normal blood pressure. So I want to get into what shock index means and how it can be a marker of severity of the hemorrhage before the blood pressure drops. Also, other signs of shock we're used to looking for, as in altered mental status or impaired skin perfusion. Before we go on to shock index, let's talk about the recognition of a ruptured ectopic, which may be even a little more difficult to diagnose immediately. Miriam, do you want to talk about this?
Yeah, absolutely. So ectopic pregnancy can present as a million different things, and it can be very vague symptoms. But the most important thing to focus on is the sign of shock in these patients. So often it is unilateral pain, so either left or right lower quadrant pain. You will often have the similar things that you would have like with appendicitis. You would have like rebound tenderness, those sorts of things. Vaginal bleeding is very uncommon in ectopic pregnancies. But it can happen. And so if that's happening, don't discount it. And importantly, again, these patients will look healthy until they don't look healthy. And Mark is going to get into that a little bit more. If you have an opportunity to do an ultrasound on patients who are having severe abdominal pain, that would be an incredible thing to do, because the signs of ectopic pregnancy on ultrasound, especially ruptured ectopic, are very obvious. And we'll get into that a little bit as well.
Yeah, and ultrasound is something that's slowly and steadily coming to EMS practice. Maia uses it a lot, as I do in my emergency care. And you actually have an image here of one of your patients, Maia. So why don't you talk us through this bedside ultrasound in a woman with belly pain?
Yep. So this essentially what we're looking at right now is a transabdominal view. And what you're actually going to see, if Mark can point it out, is this is a uterus, and that stripe you see in the middle is the endometrial stripe. So this is a patient who had a positive pregnancy test, but you don't have an endometrial stripe unless the uterus is empty. So it's empty. And then all the black that you see around there, around the bowel, around the uterus, which you don't normally see that well, is all fluid. So this is a patient who had almost 2 liters of blood in her belly. But it was actually somebody who didn't know they were pregnant before they came to the emergency department and was tachycardic, but had a normal blood pressure with a massive amount of blood in their belly. And
the ability to know this in the ambulance could help you with triage, right? And destination, right? Maia, knowing, aha, belly full of blood, I see the uterus, typical symptoms. Let's go somewhere where this operation can happen quickly.
right? And if you could call and you say, I have a patient, right? Her last menstrual period was 8 weeks ago. She had terrible belly pain. She had a bunch of fluid. Like, this is a ruptured ectopic until proven otherwise. Like, we will get the pregnancy test to prove that that's what's happened. But there's not that many other things that cause this much blood in the belly of a young woman.
And as we were discussing prior to the talk, it's maybe almost an more important indication than the fast exam and trauma. This is really important to diagnose early and get to the right center.
An uncommon image to see is the only other thing I would add is Maia trained me as a resident, and I have seen that image many hundreds of times now. It's very common, and the more you see it, the more it's likely you can just easily identify it.
Great. Let's quickly talk about the concept of shock index, because we're going to employ this in some of our cases later. And basically, shock index is a marker of impaired perfusion prior to hypotension. That's the way I think of it. So normally right now, my heart rate is probably 50. My blood pressure is probably 120. So my shock index is low. It's less than 0.5 or around 0.5. As you lose blood or develop shock for some other reason, sepsis, for example, most adults will first increase heart rate to compensate and improve cardiac output. Therefore, as the heart rate rises closer and closer to the systolic blood pressure number, the shock index is increasing. So without having to even calculate this number, if you see a heart rate that is equal to or greater than the systolic, you have a patient in shock who needs management quickly. Interestingly, there's a good bit of literature now on shock index in obstetrics, and a number over 0.9, which actually seems kind of potentially in the mild category in some of the trauma literature, predicts a greatly increased incidence of mortality and adverse maternal outcomes, like needing massive transfusion, needing a hysterectomy, needing to be in the ICU, and even developing sepsis. So we should be paying attention to this number in all of our patients who are at risk for shock, sepsis, trauma, other patients, but now particularly in women in whom we're suspecting postpartum hemorrhage or obstetric hemorrhage.
And I think the key thing is the math is easy, right? If the systolic blood pressure and the heart rate are about the same, this patient has a shock index consistent. So I think sometimes we get nervous about which is a numerator, which is a denominator. I have a sick patient, but you don't need that. Like, heart rate equals the systolic blood pressure, there is a significant problem. That's a shock index of 1.
And we'll show you a couple of cases where the systolic is what we might think of as normal, 90 or so, but the heart rate's in the 120, 130 range. That is someone who's sick and needs intervention immediately, even before the blood pressure falls. All right, so how are we going to treat someone? We've identified the bleeding, the patient's in shock, what to do next. And it's the basic ABCs of resuscitation: oxygen, and then resuscitation. And remember, there's a movement toward a CAB as opposed to an ABC resuscitation approach in traumatic hemorrhage, because advanced airway intervention in hypovolemic shock can result in cardiac arrest. And so, to the extent we're able in the field and in the early moments of emergency medicine care, we should resuscitate first. Someone who has a high shock index, or particularly those with hypotension, need blood and or fluid immediately before the airway has to be, before we provide advanced airway management. The ideal resuscitation fluid in someone who's hemorrhaging is obviously blood, but blood is rarely available in many EDs and most EMS agencies. Thankfully, it's coming more and more to the pre-hospital world, as you know, and I'm sure you've read about, and we'll share a pre-hospital case here in a minute where a pregnant woman was in shock and received blood and did well. If you don't have blood, what do? The standard of care in most obstetric units still is fluids. We want to avoid fluid overload. We want to avoid hypothermia and acidosis and dilution of the coag factors that comes along with excessive crystalloids, but we want to give the right amount quickly to reverse the acute shock and acute hypotension. So there's actually good literature on the safety of up to 1,500 mils of crystalloids in women with postpartum and intrapartum hemorrhage. And so I think it's safe to continue that approach until we are all able to carry blood products in the field. And the concept of damage control, resuscitation, and permissive hypotension apply here. Most postpartum hemorrhage and ectopics are non-compressible hemorrhages, just like a liver lac or an aortic injury or pelvic fracture. So we should titrate our fluid boluses or blood to a minimally viable blood pressure, probably somewhere around 90 is best. Keep the patient warm, ideally warm our fluids. And one thing that many agencies now are carrying and can do is the delivery of TXA. So I thought I'd go over that real quick. There's not a ton of fluid on the pre-hospital use of blood in hemorrhaging women, but there's a lot of data now on the efficacy and safety of TXA. This is a study done in the UK called the Woman Trial, well named, with over 20,000 women experiencing postpartum hemorrhage randomized to a gram of TXA or placebo. And they showed significant reduction in death, not just morbidity, but death for those who received their gram of TXA within 3 hours. So it's something I think that we can do in the field and provide benefit early on as part of the hemostasis interventions that we provide.
Yeah, I want to go back one slide and just have everybody sort of read through this. And again, right, these are things that you know. Right, this is how we manage trauma patients. I think one thing that is pretty interesting around the fluid question is, right, women who are pregnant actually have extra blood volume. It's actually disproportionate amount of plasma, but right, if we think about, right, if you say it's not postpartum hemorrhage, about a liter gives you the findings, right? If I bled out a liter right now, right, I would be in significant shock, whereas there's a lot of bleeding that occurs even normally, and they don't necessarily exhibit the signs of shock. And so I think that might be why some of the data on the fluids is sort of less condemning than the data on trauma. But I think the principles apply, right? Like give what you have until they're perfusing, but don't give more.
Agree. Why don't we go back to hemostasis here and let you go through the 4 T's just as a refresher, Maia?
Yeah. So one of the things we want to say is, right, so now that we have an idea of what the cause might be, right, I need the working diagnosis to apply the treatment. So let's talk about sort of some of the things that are unique about sort of obstetrical hemorrhage, which is how do we actually achieve treating these underlying causes? So if we talk about tone first, and I think Miriam is the greatest expert here. So Miriam, do you want to take us through sort of your thought process and give some pearls, right? You do this every day. Most EMS clinicians out there may have never done this. So what are your pearls for each one of these things?
Yeah, thanks for that. For tone, so the first thing you'll know is that, especially if a baby is going to deliver in the field, it's going to look like a lot of blood. Even if it's normal, it's going to look like a lot of blood. And sometimes that's okay. The thing that you want to do is when you don't have the specific medications like oxytocin, which I'm not sure a lot of EMS people have, that one is the one that we use to help restart the tone activation in a uterus. When you don't have things like that, the very first thing that you should do is a fundal massage. So the baby will deliver, the baby will still be attached to the cord. One thing I really want to point out, we're not going to get into fetal resuscitation at all during this, but one thing I do want to point out is if you have a clamp the cord, tie it, cut it, because the issues with the babies and the placentas, if they're not on the same level, is that you can either give the baby too much blood from the placenta to the baby, or you can drain the blood from the baby. So just clamp and cut the cord. It's the safest thing to do. After that, placentas can deliver on their own, and they will often deliver on their own within 30 minutes. But the issue is if the person is having significant bleeding, removing the placenta will start, like Maia was saying earlier, will start that contraction of the uterus much more quickly. It's a scary thing to do. I totally get that part of it. But if you can try and help remove the placenta with a couple of different mechanisms, which I'll talk to you about in a minute, that bleeding can often be reduced. So as you can see in that image on the left, the fundal massage can often alone help remove the placenta. So you just take your hand and you actually have to think about, like, say this is the uterus inside the belly. You want to get up and over it. It's going to feel really weird, like you're going really far into the belly, but you will. And you'll want to feel like a hard ball, and you do.
And I'm going to just to say that this is right. She's demonstrating an external maneuver, right? So you're feeling up and over the belly. Yeah.
Yes. Yeah. Like in that image there, that I'm just trying to show what it would feel like, and it will feel hard. And I want you to actually massage it, like really massage it. People might not be as happy about you doing that as they should be, but it will help a lot with the bleeding. Oftentimes the placenta can expel on its own at that point. If not, it's okay as long as the bleeding's okay. So something really important to remember is that fundal massage starts the compression of the uterus, and it really starts helping release those hormones like oxytocin, which is what we'd normally give in the hospital, that really helps the uterus clamp down. The best way to do it is to try and feel the top of the uterus, which you'll often feel, and really try and massage it and cramp it down. This is me on the outside of the body, and this is the uterus on the inside. And so that's the best thing to start doing if there is more blood than you are expecting. The placenta, when you're doing fundal massage, may come out, and that is completely okay, because the release of the placenta will actually help the uterus to condense back down to size. And most importantly, the one thing I want to remind everyone is start the time once the baby is delivered, from when the placenta and then the time after that, looking at until the placenta comes out, because you want to have it below 30 minutes, because that's the safest thing for us to do.
And I just want to ask a question. So if I don't know, right, is this too much blood? Because it all seems like a lot of blood. Is there any harm with initiating fundal massage if the mom doesn't need it?
Absolutely not. And we actually do it anyways, all the way, no matter what. Even if there's no blood, we'll start doing a fundal massage, and that helps release the placenta, which is what you need to do to have the uterus go back to normal size.
Yeah, because I think, and I want, like, the key thing is I want EMS clinicians to realize that this is a preventative maneuver, right? Postpartum hemorrhage is a common complication. If I can start this early, then I might be able to decrease the probability that that complication ever occurs, which is the best way, right, is to prevent the emergency.
And most OBGYNs will, right after the baby delivers, start fundal massage either way.
Maya, why don't you tell us about what you know about pre-hospital oxytocin use? I know it's rare, but some people are doing it. What do you think?
Yep. So, right, there's really good data from in-hospital about like the managed third stage of labor and reduction of postpartum hemorrhage. There are systems that have oxytocin. So as far as EMS studies, I know of work out of Australia, particularly in rural systems, that hasn't shown a decrease in postpartum hemorrhage because that's a rare, right? We have rare cases, but they have demonstrated sort of safe use and efficacy and low risk of complications. I think one key place that you should consider having oxytocin in your protocols is rural EMS, where you're going to have long transports to the hospital, because it might be a while till you have access to this drug, which is a key adjunct in management of postpartum hemorrhage. The other thing, right, if you don't have oxytocin, the good thing is that women make oxytocin naturally. And one of the ways that you can induce it is getting skin to skin, as well as initiating breastfeeding early is a way to get natural oxytocin release. So, right, if you can, right, putting that child to the chest or to breast is a way to get sort of the woman's endogenous oxytocin going. One thing I think that's really important to talk about is thinking about, how do I do this, right? How do I continue my intervention en route to the hospital in a safe manner? I think that there is a lot of people who think that we can just have mom hold baby in the arms, right? Which is not safe in the context of an accident, but there are devices. This is one of those devices that are affordable that allow when breastfeeding to occur, right, for the baby to be safely restrained. These have actually been crash tested and approved by NSEMSO. And, right, so the baby is safely transported, but allows breastfeeding to continue, as well as continuous patient assessment, which are sort of the key requirements. So I think we need to make always a plug for safe pediatric transport, and that is true here as well.
Yeah, it's just worth remembering again that skin-to-skin contact is best for mom and the baby, right? So it keeps the baby warm. It's an inducement to oxytocin production, and will help us even if we can't administer pre-hospital oxytocin. All right, Miriam, do you want to talk more about tone and trauma?
Yeah, so briefly, so the tone thing we covered, you're going to start your fundal massage right away. If anyone's bleeding, or even if they're not bleeding, you'll start your fundal massage. The next thing is trauma. If someone has a delivery right away, there's often an obstetrical trauma. So either like a perineal laceration or cervical laceration. Both of those can have significant bleeding alone, even without uterine atony. And so that's something that we have to consider. I know it is something that we often don't think about in the field from an obstetric perspective, but if you think about it from a trauma perspective, if someone has a laceration, it's bleeding, you're going to pack it, and you're going to hold pressure. It's the same thing with a cervical or perineal laceration. You want to pack it and hold pressure until you get to a place that's safe. So it is okay to use any sort of packing that you have to pack either the area, if you see it somewhere that has that is having a laceration or is bleeding heavily, to pack that area, or potentially even if you don't see it, you can pack up higher.
Yeah. And the key is you're gonna, just like, right, when you have a wound, you're gonna go to the base of the wound, right? You're gonna go up to the sort of the end of the cavity and start packing, and you can use your regular gauze. But if you have trauma gauze, right, this is a trauma, and you can use the exact same tools that you have. So, right, the last T that we really need to consider is tissue. And that is, right, the placenta is not detaching for some reason, or it detached and there was an extra little lobe there that got left behind, or this is somebody who delivered a few weeks ago and is now bleeding, and we think that there might be some tissue in there. And the key thing here is this is destination, destination, destination. All right, I am privileged to work someplace where I have OBGYN colleagues, and I will handle the resuscitation and they will get the tissue out and stop the bleeding. So get them to where you have the appropriate resources to deal with the emergency at hand. And that's why you have to consider, right, the possibility that there is retrained products, because if you don't consider it, you might not take them to the right place where it can be managed.
One thing I would add here as well is this happens a lot with miscarriages.
Yes.
So
yes.
At home, and then they will continue bleeding, and then it'll be a little bit of bleeding for a while, and then they will start bleeding very heavily, and that is very traumatic and very scary. And so I would recommend thinking about that, asking the patient, have they had a miscarriage, have they had an abortion recently, and thinking about that as well.
So this is because this can't be reiterated enough, right? So that's why we have it again, right? So the key thing is recognition, right? You cannot treat what you do not suspect. So you need to recognize, and then the key is you got to focus on the priorities of care, right? Do what you can to stop the hemorrhage. We've given you some techniques that I think you can apply tomorrow. If you see this as a patient, initiate resuscitation, and then destination, right? Get them to the right place and make a pre-notification so that the time to intervention is shortened, because, right, this is a time critical diagnosis, just like trauma, just like STEMI, just like stroke. And so the same sort of principles of how you're going to shorten that time to make the bleeding stop and the patient get resuscitated apply here.
That's good. Thank you. All right. So now let's go through a couple cases, real world cases that illustrate some of what we talked about. So this one is actually published in Pre-Hospital Emergency Care. It's out of San Antonio, one of the agencies who's pioneered the use of pre-hospital whole blood. This is a 27-year-old patient with a known placenta previa who began experiencing vaginal bleeding at home. The paramedics found her after the 911 call in the bathtub with greater than 500 mils of blood, they estimated. I would guess it was much more than that, based on her vitals and the fact that she had altered mental status and was pale. I want you to notice here in the protocol that they have both medical and trauma protocols. So this is the medical. So in San Antonio, whole blood can be used pre-hospital for GI bleeds, lots of other things, but obstetric hemorrhage is on the list, postpartum hemorrhage specifically. And note, they are not using yet a shock index. I think that may have been modified since I pulled this out of the journal, but the combination of pressure under 90 and heart rate over 110 They actually use end tidal, which we haven't talked about, but is a great marker of shock. If the end tidal cannula is on and it's less than 25, that's a marker of shock and needs treatment immediately. So she was encountered by the paramedics, got by their protocol their 1 unit of low titer O positive whole blood, and we'll discuss the risks and benefits of that in pregnancy. And note that her heart rate, actually, I got that backwards. Her heart rate came down from 97 to 85, but her blood pressure initially 68 came up to 100. Her shock index came down. She got to the ED. Fetal heart tones were heard. She went to the OR for immediate C-section and was resuscitated with a further liter of saline and more packed cells in the OR. And thankfully, both mom and baby survived. So quick thinking, a hemostatic resuscitation with whole blood saved this woman's and baby's life. What about the use of O positive blood in pregnancy? Wow, we wouldn't think we'd want to do that and risk the RH sensitization, but the folks in San Antonio have actually shown that it's relatively safe to do. The conversion to RH sensitization is rare, and if it does occur, RhoGAM can be provided in subsequent pregnancies. Miriam, do you have any comments on this? I would say that it's better to resuscitate hemorrhagic shock than worry about that sensitization later.
Yeah, there's evolving data even now about the efficacy of RhoGAM even up to 12 or 11, 12 weeks in early pregnancy. So yeah, RhoGAM is going to be something that we discuss a lot more. But I guess I would just say that like the getting the patient to the point where she can go to the OR is huge. And this resuscitation and y'all's resuscitation and like the field is huge for this patient.
And she got to the ED and the OR with better mental status and not needing heroic airway interventions, adequately resuscitated before going off to her intervention, which probably helped her have a better outcome. All right, so let's do your case, Maia.
Yeah. So the second case is a case where EMS is called, and it's just a dispatch for a woman who had vaginal hemorrhage. And she had a home delivery 5 weeks prior and had reported that she had like a fair amount of bleeding afterwards, got some IV fluids at home actually, and then it stabilized. And then EMS is called because she actually was like getting up to get in the shower and all of a sudden had a large amount, which she reported was a large amount of hemorrhage, had called her midwife who told her to call EMS. And I think what's really interesting about this case is looking at the vital signs. So this is a patient who turned out to have sort of very significant hemorrhage secondary to retained products of conception. So I think, right, key learning point is just because they're 5 weeks out, it doesn't mean it's their period coming back, okay? It can be delayed postpartum hemorrhage, and she needs to be taken someplace where there's an OBGYN. But I think if you look at her vital signs, right, her blood pressure was 129/76. And so most of us, if I gave you those vitals and say, oh, is this lady in shock? You'd probably say no. But if you look, her pulse is 120. And that is a pulse that's about equal to her systolic blood pressure. So her shock index is high, right? There are subtle indicators in her vital signs that indicated that this woman has lost a lot more blood that we anticipate. And some of this blood can be, right, also hidden. A uterus that's not fully contracted can actually hold a lot of blood that you may not see. So she had blood, she got significantly transfused, like in the emergency department, and ended up doing well.
Great. All right, one more for you.
Yeah, so I think this is a patient that Miriam and I have collaboratively taken care of multiple times when she was a resident and with other pairings, right? So I would say the most common presentation I see in the emergency department is a patient with a spontaneous abortion who is presenting with bleeding. And so here is a patient again, right? So this is a patient who knows they're pregnant, but that is also not always true. So you got to always have the suspicion who presented with vaginal bleeding and cramping a couple hours ago. And they report more than 2 pads per hour for the last 2 hours. That is one of the bleeding precautions that we give to patients that we even send home from the emergency department of sort of how do you quantify what is a lot of vaginal bleeding? And that definitely fits the bill. So again, looking at her vital signs, right, her pulse is greater than her systolic blood pressure. And these are patients who often we will ultrasound. And the most common thing that we see on ultrasound on this patient, sometimes they've actually expelled the pregnancy, but you'll just see like clot, just like a bunch of stuff within their uterus. And the treatment for that, right, is we call our colleagues in OBGYN to evacuate that out so that the uterus can contract down. Miriam, I don't know if you have any more thoughts on this.
Yeah, for me, the most common I've seen is that the pregnancy is stuck in the cervix and the cervix is being held open and the blood is just like going because the cervix can't close. Again, needs a DNC. And so that's traumatic.
Yeah. And I think it's just worth pointing out again that blood pressure looks okay, but she's sick. Her shock index is 1.2. She has significant signs of impaired perfusion and needs resuscitation.
She has a narrow pulse pressure. Yeah.
Exactly,
just like, right. And I think if I gave you a scenario and said, 20-year-old female in a high-speed motor vehicle accident, these are her vital signs, and I would give you that scenario, nobody would think 2 seconds without saying this patient is sick, right? But sometimes EMS gets called for a patient who has vaginal bleeding, and we're like, oh, it's vaginal bleeding. Maybe she's getting her period, blah, 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 blah. And not recognize that this is a patient who is really sick. And I've had these patients nearly die on me in the emergency department. And Miriam, I'm sure, so Miriam did residency where I work now, manually evacuating these pregnancies at bedside to stop the bleeding.
Absolutely.
All right, let's move to the next one. We will hear from this patient's husband here in a little bit, but let's present the case. So she's a 36-year-old who's now pregnant at 10 weeks with twins, had just been to her obstetrician who found on ultrasound that there was one embryo implanted just above the cervix, so in kind of a dangerous location, and one who was already non-viable. She went home, was told to watch for vaginal bleeding, which in fact started, and she had a pretty massive amount of bleeding at home. He brought her into the ED. By that time, she was unresponsive with a blood pressure of 48 systolic and a heart rate only of 100, interestingly. So none of us would argue with the fact that that is a dangerous blood pressure.
Yeah, that one's not subtle. You don't need to calculate the shock index.
She still has a shock index of 2, but it's not subtle. She's pale and almost unresponsive. And so just fair warning, this brings in my conflict, which is I helped create a device for this very situation called the LifeFlow. You see it there on the pump. And what she needs is immediate resuscitation. There is no amount of time that is acceptable to delay getting blood into her, or she's going to have a cardiac arrest. Can we all agree on that? And so the ED and most hospitals don't have immediate access to a big rapid infuser, nor do any EMS agencies. And so how are we going to get several units of blood? She's probably lost, let's take a guess on the panel, couple liters of blood by this time, maybe 2 liters.
At least, probably. I think it's probably more because she has increased blood volume to start with. So I'd say probably 2.5 liters.
And was then given several units of blood as her husband watched on within minutes. You can see her color. We don't have the pre-resuscitation color, but you can actually see in this image that she has fairly normal color in her forehead. Heart rate came down, blood pressure came up. She obviously did not need to be intubated, was taken to the OR for her further procedure and did well and survived. But the emphasis here is immediate resuscitation. Had that been a viable pregnancy, which I think it probably at this point, Miriam, it probably was not, but there's baby and mom to consider in that resuscitation as well. And so I think this was evidence of a life-saving procedure provided rapidly where it needed to be provided. And I'm going to show you a little data now on that we've done in obstetric hemorrhage using this device. And so this was actually presented at one of the ACOG, American College of Obstetricians and Gynecologists, Miriam's own organization. I'm not a member, but we got to present this data there on the use of the LifeFlow, here called a rapid infusion device, novel rapid infusion device in obstetrical hemorrhage. This was in my own emergency department. We had almost 30 women, fairly typical stats in terms of age and race. And interestingly, as a learning point, most of those presenting in hemorrhagic shock to the ED were from spontaneous abortion. And I think, Miriam, you validated that's what you see most often as well. Ectopics next, and then delayed postpartum hemorrhage, about 20%. And the ESI level is a marker of severity of illness on arrival to the ED. These patients had high shock indexes, over 9, all of them super high, 0.9 to 1.7, half of them, and some even in the range that I described to you before with shock index of over 1.7. So that predicts high risk of mortality. Each of those do, or complications. They got their blood and or fluid rapidly upon arrival. All shock indexes improved. That's not a sustained number, right? Most of them still need an intervention, a DNC, repair of a vaginal laceration, delivery of the placenta, whatever it is, repair of the uterine rupture. But they were stabilized to get early triage done into the OR in a timely way. And interestingly, I believe earlier resuscitation is better. These patients had a median length of stay of less than a day. They got their procedure and went home, despite a high prediction of mortality based on their numbers. A couple went to the ICU, and thankfully exactly zero died. And so this is not proof of anything. This is not a large randomized trial, but it's a suggestion that if we have a tool that can help us in those severe cases deliver blood and or fluid titrated to their reversal of shock early, we may do a lot of good. Any comments from Maureen or the docs here?
I think the key thing here is, right, early rapid resuscitation matters. And these are patients who can do incredibly well, right? You will take somebody who looks like they're near death and they really will go home from the hospital the next day. They almost do better than trauma patients, right, who end up with some big operation that keeps them in the hospital. These literally need a procedure to evacuate, engage the normal mechanisms of the uterus to clamp down
Right.
and stop the bleeding, and they will go home, and they do incredibly well. And I think that is also, right, there's a huge potential for good of recognition, early resuscitation, and then getting them to where they can get that procedure quickly.
And then I would add on the recognition part, the world that we live in right now, people are often self-managing their own abortions or having more miscarriages that they don't feel safe getting cared for, and asking the patients, truly asking the patients and seeing what you can do from that perspective, and then being able to engage. So like that 5-minute to 30-second history really matters.
Great. I forgot this one slide, just kind of showing improvement in vitals, but don't neglect the shock index. The average here was actually 1.1. This is an incorrect number, and then dropped. So early resuscitation matters, gets you to that point where you can even ask the question maybe that you're talking about, Miriam, if someone's lethargic, unresponsive initially, and then get on to their definitive intervention. All right, so I think we'll stop here and open for questions. Hillary?
Great. Thanks everyone for being here. We are really thrilled to have with us a special guest, as Mark noted, and that guest is the husband of the patient in case number 4. His name is Will, and he's here with us today because he recognized the value of following up with his caregivers after the traumatic experience that he and his wife had with their twin babies. And so, Will, thank you once again for joining us. And you know, from your perspective, we always learn, EMS providers especially, a lot from patients and their family members when they come back and tell us what happened. Can you just walk us through that day for us?
First off, I appreciate you having me here today. Number two, watching that slide, it kind of hit home a little bit, and I actually teared up a little bit reliving that because it's quite a blur when you're in that situation. My wife was, as you saw in case number 4, she was 10 weeks pregnant. This was our second set of twins. We had a prior miscarriage. So it was already pins and needles for us, but unfortunately we had an OB appointment that morning. We saw signs of a miscarriage beginning. We had no idea or concept why, but to make a very long, dramatic story as short as possible, my wife later throughout the day became obvious signs of having a miscarriage and bleeding. It was very light to begin with. It was nothing else to be too concerned about. As the night went on, it it got worse. And unfortunately, in our situation, it was a little unique because the common OB response was, are you feeling a pad more or one pad more than an hour? During that process, when she's by herself in the bathroom, you're not there to help her, and she can't tell either. So as time went on, it became evident that she was losing a fair amount of blood, but of course, being stubborn, she was fine. She was coherent. She's talking. Ended up with her going to the bathroom, and the next thing I know was a crash. She had fainted, fallen forward, ended up flooding our bathroom. So not only she's bleeding, she's soaking wet, and we realized we had a major problem. Top of that, she had also sustained a concussion. We didn't realize she picking up a limp noodle is not what I would really want anybody to have to do, but that's exactly what she was. I was able to get her as fast as I could to the truck. I could not wait for EMS at that point in time. We got her in there, and as you saw, she came in with a blood pressure 48/27, as I basically pretty much took out the storefront of a hospital. But sitting in that room, it's kind of surreal, being in that room watching with the entire ED department as those monitors slowly, the numbers and blood pressure kept ticking down, realizing that she had to have blood. And it truly is, and I know this isn't a LifeFlow deal, but I watched that little device get handed off to a nurse, and literally the life got pumped back into my wife. It was moving, but it was definitely a lifesaver. It was a traumatic event, but I'm glad she's doing much, much better. She's recovered, and on the happy thing, we're actually expecting another little one. We are pregnant, and we're due May 14th. So there is a happy ending there.
Awesome. That's great news, Will. Thank you.
Thank you.
Thank you, Will. Amazing story. Always great to hear what happens with our patients, and we congratulate you on your baby.
I appreciate it.
All right. We have so many questions, amazing interaction. Thank you so much, everyone, for diving into this topic. And we completely understand how much knowledge you want to have, and maybe lacking. This is a tough topic for a lot of people just because of the lack of calls and some other scary things that go along with it. We will stick around past the top of the hour. So if you're all able to stay with us, we'll keep answering questions as much as we can. We had two questions that we said we would answer earlier in the webinar. They were asked, and we'll answer them now. Mark, you're the shock expert. Tell us about a general heuristic or way for us to accurately estimate blood loss. It's definitely a problem.
Yeah, I don't know that I'm an expert on that topic. And as Will mentioned, not only had his wife Sarah become unconscious because of blood loss, she'd actually knocked the toilet off of the wall.
Right.
So that there was flooding, and there's no way he could estimate the amount of blood. Even in the first case we presented, how someone estimated 500 mils of blood in the bathtub, I don't really know. So maybe our ED and obstetric experts could give me a little better idea about how you even begin to go about estimating. And number two, doesn't matter. There's a lot of blood. The patient has evidence of shock. That's what really matters. But Miriam, Maia, how do you go about estimating a blood loss?
I think the key thing is that the visual blood loss does not actually matter. And that's because in addition to being sort of poor estimators of that blood loss, you can have occult blood loss, right? The uterus can hold a lot of blood that hasn't exited yet, but it's definitely exited, right? The vascular system of the patient and is not circulating. So I think this goes into stressing is don't go by what you see. Go by the patient's vital signs and your clinical suspicion of hemorrhage, because the only thing that saying, I don't see that much blood will lead to is a delayed recognition of significant hemorrhage and a delay in time critical intervention. I don't know, Mary, you're shaking your head. So I think you agree with me.
I completely agree. And I also would add the very same thing for ectopic pregnancy, because ectopic pregnancy, you don't see blood, but you do see vital sign changes. And particularly you'll see pulse changes first. And I think that that's really important, especially in young, healthy women, is when you see things like that look odd and different, anticipate that something else is going on and the blood is not going to be coming out of the body.
And one interesting thing you pointed out, Maya, was that in your case of ectopic, there was 2 liters of blood in her belly, and she came in awake, right? So Will's wife probably had lost 2 liters and was still conscious before she lost more, and then suddenly it developed altered mental status. So a lot of blood. It's going to take a lot of blood loss to produce these severe mental status and vital sign changes.
And like Maya was saying, yeah, exactly, is that women who are pregnant have more blood. They have almost 1 liter more blood. And so again, the vital signs changes will not look like typical losses.
Great, thanks everyone. We also had a question earlier about would any facility with a general surgeon be able to handle these patients, or do we really need to think about one that has OB, labor and delivery, that kind of thing? Maya?
Yeah, and I think this is going to be location dependent, because I think you have to think about what this patient needs, right? They need hemostasis and they need blood. And so the key thing is, right, like if it's going to be a really long transport to get them someplace with an OBGYN and they are not going to survive that transport, then I need to think about getting them someplace where they can be resuscitated, and a general surgeon can find a uterus. Right. So sometimes we don't get exactly what we need, like what we want, but we can get what we need. And so you have to sort of think about the risks of a prolonged transport compared to sort of initial resuscitation. The other thing is there's some patients. So for example, in a miscarriage, right, as an ER physician, I don't do a DNC, but there's lots of patients where I've gone and looked and I see, right, as Miriam described, like the products of conception stenting open the cervix, and I pull it out and I stop the bleeding. So it's really ideally you take them someplace where you have an OBGYN and blood, but we understand that we don't have, right, like not every region has that as a close resource. I do think communication with like your med consult line is going to be really important to that incoming facility, so that they're aware, because especially a lot of smaller emergency departments, they might not actually have blood in the emergency department. They may need to call somebody in from home, right?
Wow.
So pre-notification is still going to be really important. And it also allows you to have that sort of risk benefit discussion of the destination, so that they know what's coming.
I would also add, oh, sorry.
Go ahead. No, you go ahead. And then I have a question.
Yeah, I would also add that when someone is bleeding, if you have a choice between blood and OBGYN, I would choose blood.
Yep. I know we won't get to all these questions, but there's so many coming in on packing, cervical lacerations, packing, vaginal packing. Do you do it or not? Can you two just offer your expertise on how in the world you know what to do in the pre-hospital setting?
Yeah, so I don't practice in the pre-hospital setting, so I'll just say that to say it. So Maya can correct me if I'm wrong. What I would say is that the majority of bleeding is going to be from at-knee. If you don't feel comfortable packing, that's fine, but I would always start with a fundal massage either way. The time when packing comes in and is going to be important is if you do a visual inspection. You don't have to do any big exam, but just do a visual inspection on the outside and you see brisk blood coming and you feel the uterus being hard. I know that that's a weird thing to kind of visualize if you've never felt a hard uterus, but it will feel like a rock versus you'll feel nothing. So if you feel like a rock and there is brisk bleeding still happening, it is very reasonable to pack the vagina. You can pack the outside of the vagina if that's all that you're comfortable with. You can pack the inside of the vagina. A cervical laceration is something that's incredibly rare, but especially in precipitous delivery, which is often what happens in the outside of the hospital setting, it is a higher risk. So if you're not comfortable with it, no need to worry about it. But if there is something, if you're really far away, if you feel like it's something that you can do, it's not unreasonable.
Yeah, I think the key thing is, Ryan, we're always going to treat at-knee first. And if you don't feel this big deflated uterus, if you feel like, sort of like a hard grapefruit rock in the pelvis that you can feel, if you feel that and they're still bleeding, right? Like, I think the big thing is we don't think twice, right? If I said somebody had a junctional gunshot wound, we don't think twice about packing that wound, but because we're like, oh, it's a vagina, like I can't go there. There's a possibility that if a patient has a cervical laceration or significant vaginal laceration that you can achieve enough hemostasis to get them there. So when I think about the algorithm, I think treat the most likely thing, which is uterine at-knee, treat it aggressively and continue fundal massage, even if you feel it hard, because a lower uterine segment might actually still have at-knee while the top of the uterus has gotten hard. But then if you feel that and it's still bleeding, go ahead and pack. And I think if some people say it's not in our scope of practice, it's not in our protocol, I encourage you to talk to your medical director about it. Because when we started teaching this here, people were like, we haven't done this before. We were taught in the EMT class never to do it. But I talked to the OBGYNs in our area, the medical directors, things, and we all were in concurrence, like, of course, that this is something that's quite reasonable for somebody to do because it's potentially, right, a life-saving procedure to do that.
How about, we're getting a lot of questions on TXA as well, dosing, when to give it, what the triggers are. I think the woman trial kind of answered the 1 gram treatment initially as being helpful in saving lives. What are your thoughts, Maia, on the triggers pre-hospital for that? For any bleeding, for bleeding with signs of shock, when do you want to give it?
I think I would defer to Miriam to say, like, there's no reason that we would do it differently than they would do it in the hospital. I think if there's signs of heavy bleeding and signs of shock, the downsides are little and the benefit is great.
Absolutely agree. And there's also been quite a few questions about that with oxytocin as well. Oxytocin, anytime anyone delivers in the field, I would absolutely give oxytocin if you have availability of it. There's not a reason I wouldn't give it. TXA, if the person had the baby, everything looks fine, no bleeding, maybe you don't need to give TXA. If there is bleeding and you're concerned, or if there's atony and you just feel like kind of nothing, none of that grapefruit that Maia was talking about in the uterus, TXA is not a bad thing to give either. It's not gonna be harmful, but using oxytocin every time in the field, I would definitely recommend.
We got an interesting question about MAP versus systolic, and I'd be curious on your opinions, both of you, on that. I tend to think about systolic first. It's an easy number to remember. 90 is a great threshold for hypotension. In sepsis, the pulse pressure could be wider. In hemorrhage, there's vasoconstriction. The pulse pressure could be narrower. I don't tend to think about MAP that much. And what do you think, Maia, about what number we should rely on?
This is going to be advocacy. I'm going to say systolic with a manual blood pressure, because most people don't realize that our monitors, actually, the systolic and the diastolic are calculated parameters based on the MAP. So the MAP is actually the accurate number. So I think patients who we think are in shock, we should be getting manual blood pressures. That is true for trauma patients. That's true for hemorrhagic shock patients. And I think that'll get you a more accurate estimation of what is actually going on.
You guys might want to see James Rowland from Australia's comment here on the great effectiveness of the combination of fundal massage and oxytocin. They're using pre-hospital there a lot. So Miriam, any comments?
I mean, that's exactly what we do in hospital settings. Immediately after the baby delivers, we deliver the placenta, but it doesn't have to happen. Fundal massage, incredibly important. Oxytocin initiation at the time of delivery is incredibly important as well. So,
and James, I don't know if you can answer verbally here or not, but are you giving IM or IV oxytocin? I'd be curious about that.
I'm not sure if he can answer verbally, but I think earlier he put in the chat that they were doing IM oxytocin.
Okay, great.
And there is a study that was published in Pre-Hospital Care within the last year that actually looked at pre-hospital oxytocin for management of active management of third stage of labor by EMS. And they did demonstrate safety. Not all patients consented to have that, but a bunch did. They couldn't look at the outcome of postpartum hemorrhage on that study design, but they definitely demonstrated like a safety profile for that as a practice.
Hello, can you hear me?
Yes,
Yeah,
we can hear you.
Oh, there we go.
Yeah,
Perfect.
hello, Mark. Yeah, answer your question. We're giving IM oxytocin post the birth, just making sure there's only one baby in there. And then we're following up with a second if there's PBH. And then we're also giving an IV infusion of 20 units on way to hospital.
Great. And you have, as I understand, you have long transport times because you're going way out in the rural areas, right, James?
Yeah, we could have up to 2-3 hour transport time, but also additionally in the city, we could have a 5-minute transport time and still give the IM oxytocin.
And I'd be curious, in your 3-day course that you give for your obstetric emergencies, are you teaching packing for continued bleeding despite fundal massage and oxytocin?
We're not really teaching packing. It's mainly focused on oxytocin and some of the other obstetric emergencies, but we're not really doing anything internal.
Okay.
At this stage.
Thank you.
And I think that's important, what James just said about giving the 10 units of IM oxytocin, but then if you have other oxytocin, you can do a continuous dose, and that's great.
And I know that all of you, as a paramedic myself, feel the same way I do, which is that this is incredibly helpful education. I learned so many things here on this 1 hour webinar that I never learned when I was in the classroom. So I think that we need to thank our dynamic, amazing, knowledgeable presenters, Miriam, Mark, and Maya, our special guest, Will. Thanks to Maureen, who couldn't be here for the live portion, but contributed ahead of time. And we hope that all of you find really great clinical pearls that you can use in the field in the future, and that you'll be back here for our next webinar on Prodigy. Happy holidays to everyone, and please stay safe. We'll see you later. Bye.